It's hard to imagine doing a trial to decide the best regimen. We're all applying our knowledge, our art, our experience. And I'm curious, how would we design a trial to answer Amir's question? How do we give this drug? Because every patient is different.
This is a nightmare. I mean, Dan and I have been actually together on a couple of different meetings where the goal was actually to try to get an expert consensus. And I think we were cracking up at the end that not only could we not get an expert consensus, we can even decide, you know, you can't even decide what you want to have for lunch, let alone this. And in Colorado, apparently there are no fungal organisms, so they don't use it. Dana-Farber doesn't use antifungal prophylaxis. I absolutely do. MD Anderson does. I do marrow on day 21. So here you have a lot of people who treat a lot of AML and kind of think we know what we're doing. And we concluded at the end of this that we are either all a bunch of geniuses or all a bunch of idiots, because we absolutely couldn't agree on anything. And the problem is that bespoke medicine is nice, so you want to take individual excellent care of your patients, but it's nerve-wracking not to be able to figure out some consistency. And I would say the closest we have, I mean, we've got the Bible and the Torah, and we have Dan's paper in leukemia, which all of the PAs, if they can't at least tell me about that paper and exactly what it says, I don't even want to have a conversation, because at least that gives you something to hang on to, that please check the marrow. Please don't be on day 60 of Venetoclax without a bone marrow biopsy. Please don't add an antifungal. If you're going to add it, you've got to down the dose. So at least certain basic principles have to be absolutely, absolutely applied, even if the subtleties of exactly what day you do the marrow and exactly which antifungal can't be mandated.
I think it's in the Talmud, Gail. It's really far in there. You gotta.
I was sure of that, but I wanted it to come from you.
No, but I need to take I need to push back on Amir's comment about patients who are very pancytopenic, maybe sick with a fungal infection. You don't want to give them Venetoclax in the first cycle. I disagree.
I didn't say that. No, I didn't say that. I didn't say that patients are very sick with their leukemia. I don't want to give Venetoclax.
Oh, okay.
There are some patients who, because of their functional limitations or of their age, I may worry about significant marrow suppression with the combination, and I may choose to give monotherapy with HMA. Again, everybody's different, but that's been, do I see 85, 90-year-olds with AML who I want to treat? I do.
But you've seen deaths from aza-ven in some of those patients from time to time. We get very arrogant with this and say, everybody, you're 100 years old and this and that, we're going to do aza-ven. Every now and then we get bit and say, ooh.
This is a bad disease, but having count recovery faster is better than count recovery.
And that's the key here, because the last patient I just treated, 90-year-old man, okay, who had fungal pneumonia, but cleared his blast quickly. I did the marrow at day 14 and it was clear. Started him on GCSF, counts came up. Absolutely. You've got to get the leukemia to go away for the counts to get better. And that's what this regimen gives you. But I think, you know, what Gail said is exactly right. There's not one size fits all. And Mark said it, there's an art to giving these regimens. And so the community needs to learn about how to do this with time, experience, and reaching out to people.
I also really worry, and I just want to emphasize this point, that so I worry that people got on the wrong bandwagon somehow with Venetoclax because of the original CLL approval. And obviously in practice settings, there's an awful lot more CLL than there is AML. And everybody knows the ramp up, the TLS, the watching all of that. That's all the stuff that we don't care about in AML. Ramp up, I don't even ramp up, I just get there. The TLS, I think I've seen one laboratory TLS when I had to report. But I mean, these are the kinds of things I can say this. I'm not advocating in any way not to be careful. I am very careful. I admit these patients unless they live within 3 feet of the hospital entrance. I treat them as induction. I watch them very carefully. But what I'm watching is not a I don't even know where to find a 20 milligram dose of Venetoclax or 50 milligrams. That's for CLL doctors. But it was a wrong focus of the toxicity. And somehow myelosuppression got into the, oh yeah, well, AML therapy is myelosuppressive. And this is different. This is different. And it should be regarded differently. It should be regarded as intensive induction, which is my final point, which Harry and I love to talk about, which is the end and death, hopefully, of fit and unfit. So there too, right? There are fit people, there are unfit people. You worry about everything with aza-ven. You want to give everybody this high response rate. You want to get them into remission. Whether or not you do a transplant or send them on a cruise after they get in remission, never mind, just get them into remission. But the point is that you can't just call somebody unfit forever and say that, well, they're not a candidate for a transplant because they might be a candidate later. Similarly, you can't necessarily call somebody fit forever, because if they have a terrible time with induction and they blow up and have infections, that patient may actually want to go on or need to go on to some sort of maintenance. So flexibility in thinking.
I agree. And we're going to come to the end of this part of the discussion. I'm going to turn to Mark for that, but I just want to come to a few other quickly endpoints from that VIALE-A that were important. You know, we talk about a CR/CRI rate of about 2/3 of patients in the study, but what's really impressive to me is that they weren't just CRIs, almost all of them were also CRHs. Mark, what's a CRH? CR Bahamas, right?
Sierra Bahamas, yes.
Okay. You can go to the Bahamas on it. I mean,
Yes.
the counts have truly recovered. The other thing was that patients who were transfusion dependent at baseline had a higher rate of transfusion independence after aza-ven than after azacitidine. We're still waiting to see the quality of life data, but it gets to the point that Gail just made about fitness is important. If you look at the hazard ratio for survival in the patients under the age of 75 in VIALE-A, it actually is pretty close to unity. But remember, for the patients to be under 75 to get on the study, they had to have very poor performance status or comorbidities. And so we really need to continue to take very close care of these patients, especially older patients with infirmities that may make them at higher risk of infectious complications and bleeding.